Just gonna wait a few while people get on, and then we'll get going. Morning, Ken. Hey, Beth. Helen. Hey, Julie. Anybody else have freezing temperatures this morning? It's 32 degrees this morning. It's horrifying. Terrible. Hey, Carol, are you in Panama still? Yeah, 33 in Columbia, 32 in Boonville. Bad. Hey, Josh. Stacy, how are you? Michelle. Julie. Wow. We do have the sun. That's true. This is just like my classroom. I usually teach on Zoom, so you guys can't talk to me except through comments. But when I teach, it's on Zoom, so we get to interact. But it takes 5-10 minutes for everybody to join. Hey, Lynn, Ross, Barbara, thanks for coming. So I hope everybody had a good Easter, even though it was kind of strange. But we did manage to have a nice dinner. And no kids, so no Easter egg hunts. At least here at this house. I never had, Eileen, I never had allergies until I moved to Oklahoma. So I grew up here in central Missouri, never had an allergy. And when I moved to Oklahoma, everybody says, oh, you'll have them within 2 years. I did. They stayed with me. So little allergy symptoms and a cough. And of course, right now you're running around, if you have a cough or whatever, everybody thinks that you're going to infect them. So I stay home most of the time. Hey, thanks, Randy. I'm almost 60. I don't know how that happened. Actually did my hair this morning, put on a shirt and took change out of my pajamas. So you guys didn't have to see all that. Now we have a student. Hey, Emmett, this is not on the test Thursday, just so you know. But you're going to remember some of this from Thursday. So anyway, what got me doing this is watching a video from an ER doctor that I think he did about a week ago. And it got me to thinking, and I'm not the only one thinking this way, so I don't think I came up with this entire methodology or thesis for this. However, he did a video, I think it was on Medscape, and then he did a follow-up video on Medscape where he was kind of interviewed. So his first one was just him talking about his experiences. So he's an ER doctor who I guess started his own ICU for this virus. And what he was saying on this video, and it was about a 9-minute video, and he just kind of sitting here at his table like I'm doing, and basically was talking about the fact that this just didn't make sense to him as a clinician. So he's an ER physician that, so not a critical care physician, but of course he's making emergency decisions. So not specifically a critical care doctor like an ICU doctor. But what he was seeing clinically didn't make sense to him. So he'd seen patients with acute pneumonia, and he'd seen people with ARDS, so that's adult respiratory distress syndrome, which is what everybody's focused on. He was afraid. Hey, morning, Ned. Hey, Tammy. And yes, we're going to talk about your ACE2 receptor. The other stuff might be a little bit too deep, but the ACE thing is coming up. So anyway, he put this up, I'm going to say last Sunday or Monday, and then his follow-up was on Monday as well. And what he was saying was a typical respiratory distress patient or somebody that's having respiratory failure is really struggling. Their muscles fatigue. It's kind of like if I told a friend yesterday, I said, if I told you to bench press 250 pounds and do 25 reps, you wouldn't be able to do it because you would use up your oxygen and your oxygen reserve in your myoglobin in your muscle. So that's what happens with respiratory failure. You get hypoxic, your oxygen goes down, and eventually you just struggle so much to breathe that your respiratory muscles, including the accessory muscles of respiration, just give out their fatigue, just like if you overdo it in the gym. And that's when they start putting tubes in and breathing for you while they let your body just try to heal itself. What he was saying in this video is that the people that usually go into respiratory distress and become so oxygen depleted that they need intubation, they're gasping for breath, they can't talk, of course they're turning blue and cyanotic and all that. And that's not what he was seeing. He was basically seeing patients who were able to breathe, but they were becoming cyanotic and breathing. Their respiratory rate would go up. And typically, when you get respiratory failure, you're going to get a heart rate jump as well. So your heart rate goes up, and he was not seeing that either. So what he was seeing was cyanosis, people turning blue, oxygen depletion. Similar to what he said was like high altitude sickness. So Emmett, you remember talking about that Thursday or last week. So high altitude sickness. So that happens because the pressure of oxygen in the atmosphere has decreased so much that if you're not acclimated to a higher altitude, you're just not able to oxygenate or breathe appropriately. Hi, LaDonna. Hey, Steph, Linda, Jeremy. Wow, I'm seeing you all. Hey, Rob. So basically, he's saying this looks like high altitude oxygen depletion. So he described this difference, and we'll talk about the lungs here in a minute. But he described the difference as trying to aerate a balloon that had a thicker wall. So that would be a compliance issue, which is what you see with consolidated pneumonia and ARDS, respiratory distress syndrome. And he said what this looks like is a balloon with a thin wall, so that the compliance is actually higher than it usually is. And the lungs have to be compliant and elastic to work correctly. So this has been called, coronavirus, which is really basically a member of the cold virus. So to get ready for this, I pulled out my Harrison's Principles of Internal Medicine, which I think is from 2015. So it did have some stuff on coronavirus in it, but not a lot. So SARS is acute respiratory syndrome caused by a coronavirus, which was, so the SARS was identified in China. Well, it started in China in 2002. It was identified in February of 2003. Morning, Alex. I hope your weather's better in California. It's cold here. Okay, so basically what you've got is a different type of coronavirus. So it is part of the cold virus, just common cold virus, but the SARS version is different. So, you know, the virus of SARS or coronavirus is kind of like the rhinovirus, which gives you a runny nose. And a typical coronavirus gives you a common cold. They're so variable, it would be very difficult to come up with a vaccine for that. So overall, they haven't done that. They haven't been able to do that. Well, this one they've renamed. So it's been coronavirus, and it was COVID-19. The 19 has to do with the year that it was identified, I guess, or became a clinical entity. So it was December of 2019. And now they've renamed it as SARS CoV-2. So coronavirus 2. Hey, Diana. Oh, LaDonna, you lost sign. Can everybody hear me? LaDonna can't hear me. There's Tracy. So what we're seeing, well, first of all, let's talk about what's a virus. It's not always a bad thing because your body can create its own viruses to fight off inflammation, inflammatory conditions, and disease, et cetera, et cetera. But if you inherit or you get a virus, it has to get into your body. So this one apparently is aerosolized, which is why they're saying that that it's spread by droplets. So and sneezing, they say, isn't part of the deal. They're saying that coughing, and it's a dry cough, remember, which is not something you see with pneumonia. Pneumonia usually has a wet cough. Anybody that's ever had pneumonia or anything like that, they don't dry cough, they wet cough. So this virus, if you sneeze, you put out 4 million particles, droplets, basically. And if you sneeze, it's about 90,000. That's the reverse. Sneezing is about 4 million, coughing is about 90,000. So they keep talking about the cough spread. And of course, then it can live on metal, et cetera, for hours to maybe a couple of days. So what a virus is basically an RNA strand. Okay, so you know what DNA is. That's what gives you, that's part of your genes and how you make proteins and all that. So virus is either single-stranded or double-stranded RNA. So just little proteins. This one's single-stranded. It does have an envelope and it has a capsid, so it has a little head on it. But in order to do its thing, it has to get into a cell. And in order to get into a cell, it has to have a receptor. Okay, well, this receptor is ACE2 that's on a type 2 pneumocyte, and I'll explain what that means here in a minute. So when a virus enters a cell, it does its thing, not in the nucleus, it does it in the cytoplasm, which is the little kind of gooey stuff that all the organelles in the cell float in, and then the cell wall is what keeps that all together. So the virus has a messenger RNA that goes through a process called reverse transcriptase to form DNA, and DNA is how you make proteins. So what a viral messenger RNA does is reverse transcriptase. So usually it reverse transcriptase the DNA so it makes proteins. Some of them are structural to support the virus. Some of them are non-structural, and that becomes kind of an important part of all the information that's come out in the last 7-8 days. Some of the studies that are being done, of course, they're fast, have been published within the last 3 to 4 days out of China. And so that non-structural protein that this virus makes seems to be a major problem. Okay? Okay, so lungs. What do lungs do? They help you aerate and get rid of CO2. So when you inhale oxygen, that is transported in the blood to your tissues where it's unloaded for metabolism purposes, creates CO2. CO2 is then brought back to the lungs and blown out when you exhale. Okay, so it's basically the lungs are important. When I teach physiology in every system, I say this is the most important part of our entire body. Well, the lungs are kind of a big deal. The digestive system, cardiac, everybody thinks cardiac is the big system, but the cardiovascular system is basically responding to your lungs and your kidneys for the most part, and your brain, of course. Okay, in a lung, there's a conducting pathway and there's a respiratory pathway down to when you get to the tertiary bronchioles and the alveoli. So the alveoli are the little sacs that exchange O2 and CO2 across a very small space. So the pulmonary capillaries are lined by one cell. Okay, so that diffusion based on pressure differences can occur. The type 1 alveolar cell, so there's two types of cells in an alveolus. The type 1 is the one that is there for gas exchange, and the type 2 pneumocyte, or alveolar cell, is the cell that produces surfactant. And surfactant increases surface tension in the alveolus so that it doesn't completely close when you exhale. If you didn't have surfactant, every time you exhale, many of your alveoli would just completely close, and it would be harder for you to breathe, similar to if they were filled with pus or water, fluid, whatever, which is what happens in pneumonia. Okay. What they have found, and this goes back to the original SARS and coronavirus, is that the type 2 pneumocyte has a receptor on it called ACE2. Okay, so ACE, if you've ever heard of ACE, or angiotensin converting enzyme, is involved with vasoconstriction. So an ACE1 receptor responds to the renin, aldosterone, and angiotensin system from the kidney. So when your kidney senses that there needs to be either vasodilation or vasoconstriction, it will send a signal to angiotensin converting enzyme to inhibit it, or to form angiotensin 2 from angiotensin 1. And angiotensin 2 is the most potent vasoconstrictor in your body, and it's involved in hypertension and high blood pressure. So there are drugs that will inhibit that enzyme called ACE inhibitors, and they work on ACE1 receptors. So the ACE inhibitors relieve the vasoconstriction of angiotensin 2 so that your blood pressure goes down, okay, and vice versa. ACE2 seems to be a vasodilator, okay, so that receptor is involved in dilating as opposed to ACE1 and angiotensin 2, which constricts. ACE2 is located mainly in the enterocytes in your gastrointestinal system and in your lung. Okay, so the type 2 alveolar pneumocyte has an ACE2 receptor, and that is the receptor that lets this virus into the cell itself. So if ACE2, and there appears to be another enzyme or coenzyme protein, I think it's called fumin or fermin, I can't remember. And I can't share I haven't figured out how to do a share screen so I can show you what I'm talking about and what study and all that. But there's a different combination from the original SARS, which didn't require that fermin, fumin. This one, that is involved, and it helps in the structural replication of the virus. So when the virus starts making DNA, it is replicating itself. And it will replicate itself until it explodes the cell and causes what's called cytolysis. So it lyses the cell and causes cell death. Okay. Okay. Once the cell dies, then you have material coming out of the cell, the cytoplasm, etc. Remember, the alveolus and the pulmonary capillary are side by side. So that involves continuation or cascading cell death. So you get more and more cell death, and eventually your immune system notices, oh, there's all these cells dying. Now, doesn't mean that you don't have cells dying all the time, because you do. It's called apoptosis. It's a normal thing. It gets worse with age. But you do have a way to get rid of cells that are dying, and they're usually programmed to die. This one is not programmed to die. It's being destroyed. Okay. Eventually, and in your alveolus, you have macrophages. And macrophages come from monocytes, which is part of your white blood cell system. So macrophages phagocytize or eat. So they engulf bacteria, viruses, dead cells, debris, and present that material to the lymphocytes. And the lymphocytes are what carry your immune factors. Okay, once the lymphocytes and the macrophages realize, ooh, there's a foreign body in here. Hi, Jen. Hey, Zach. There's a foreign body in here, and we need to get rid of it. So the immune system starts releasing what's called cytokines. Okay, so the cytokines are, and there's 3 of them are associated with this particular CoV-2 virus. And it's not important what they're called, but they've identified 3. Okay, so what you're releasing is interleukins, interferons, and tumor necrosis factors, and that is exactly how your immune system works. So it has to go there and clean up all these foreign bodies. Well, eventually that cell death, that cascade of cell death, makes it so ridiculous that you get what's called a cytokine storm, and that's when people start getting the respiratory failure. Is that cytokine storm of interferons and interleukins and tumor necrosis factor, where the immune system is just going crazy trying to get rid of this. So you get increased fluid in your lungs, kind of like a pneumonia. And you remember, most pneumonias, this is a bilateral thing. So you start getting fluid-filled lungs. You can see that on x-ray. So the x-rays are showing consolidative filling up of the lungs bilaterally. Most of the time, pneumonia is lobar. A lot of times it's unilateral. This is always bilateral. So this is always a bilateral thing. That leads to consolidation and eventually pus. And the consolidation makes the lungs more difficult and stiff. So if you think about when babies are premature, most of them, I'm going to say 60% that are born at around 28 weeks have respiratory distress syndrome, or what's known as hyaline membrane disease. It's almost like hyaline's related to cartilage. So think if your lungs were starting to fill up with cartilage, how hard it would be to ventilate. So to treat that, they give premature infants surfactant, because the reason they get hyaline membrane disease is their type 2 pneumocytes haven't started making surfactant. If you give them surfactant and high-dose oxygen, then you can reverse that. Some of them wind up with oxygen toxicity for life, so they stay that way. An adult person already makes surfactant with type 2, so giving them surfactant doesn't do anything. You do have to give them oxygen. And so what this ER doctor was saying is you don't get the you don't get the high compliance, or the higher compliance of the lung, the lower compliance of the lung, so a stiffening lung with decreased elasticity. So it's elastic versus compliance. And so what he's saying is these lungs have a higher compliance and lower elasticity. I think I got that right. Nope. See, I took notes, so I keep looking over here. And sometimes I look smarter with glasses, but I gotta put them on to read what I wrote. Okay, so it has to do with compliance and elasticity, and he's seeing the reverse of what you would see with somebody that has pneumonia or ARDS, where they've got really stiff lungs, where they have to use pressure. His viewpoint is, yes, you have to use oxygen, probably higher levels of oxygen. And with high altitude sickness, you use hyperbaric oxygen, which is 100% at like 1.5 to 1.7 atmospheres pressure. But the problem is you have a you have a lower, like a thinner lung. So if you start putting higher pressure on a thinner lung, his feeling is that's actually causing more damage. So he's afraid that, his viewpoint was the paradigm may not be right. So this, ooh, we need more ventilators. Yes, we're going to need ventilators because people do go into comas and get respiratory failure. He talks about one patient that was talking to him and saying, please don't intubate me. Please don't intubate me. And he says, well, how am I going to decide when to intubate this lady? Whereas most people that have respiratory failure and ARDS, they would let you intubate them. They just would. They can't really talk to you. Okay, so basically, he's saying, well, what if there's a respiratory component? So that might be the way it gets in. But what if the actual mechanism of destruction is different than ARDS? And that was his thinking. He didn't say what he thought necessarily, but this information coming out of China in the last 7 or 8 days is kind of showing it to be that way. So one of my high school classmates put this up, and she said, what if it's a blood disorder? So what got me thinking about this was, I think, well, what else would make you hypoxic? What else would make your oxygen depleted? And what it would be carrying of the oxygen. So mostly when you breathe in, you don't just dissolve oxygen in your plasma. So most of it is bound to hemoglobin. Hemoglobin is 97% saturated with oxygen as it goes through your system. So when it comes out, so your PO2 in your arterial blood coming out of your lungs and your aorta, PO2 is about 100, and then you deliver about 25 millimeters of mercury pressure of that oxygen to your tissue before it comes back. It takes about a minute for one red blood cell to go all the way through your cardiovascular system, and so from your aorta to come back to your left ventricle takes about 1 minute. Okay, so you usually pump out 5 to 5.5 liters of blood per minute. So you breathe in the oxygen, some of it's dissolved, like 0.3 cc's per cubic millimeter of blood. Most of it's bound to hemoglobin. Hemoglobin is a quaternary, means it's got it's like almost 4 dimensions structure that's made up of 2 alpha and 2 beta chains called globins, so alpha and beta globin. And then there's a heme group on each one of those chains. So the heme group has this huge chemical thingy, but in the middle of it is an iron 2+ or a ferrous ion. So it's got a charge of 2+, so Fe2+. Okay, so that iron is what oxygen is bound to, and that is what's carried. So that's how it's carried through the blood. Okay. Okay, so this is how much give you got as far as oxygen. So each red blood cell has about 280 million hemoglobin molecules in it. One red blood cell, 280 million hemoglobin molecules, and each heme group can carry an oxygen molecule. So that means each hemoglobin can carry 4. So a red blood cell has over 1 billion oxygen molecules in it. Okay. You make about 3 million red blood cells a second out of your bone marrow. Okay, so 3 million per second. The red blood cell count, I think, is about 4 to 6 million red blood cells per microliter of blood. So a milliliter is 10 to the minus 9th of a liter. Microliter is 10 to the minus 6. So you got a bunch of oxygen carrying capacity. However, if you have a hemoglobin problem, which can happen, there's hemoglobinopathies, and the one that got me thinking about this was carbon monoxide, and we just taught that in physiology within the past week or so. Carbon monoxide poisoning. So your house has a carbon monoxide monitor in it, because carbon monoxide can kill you pretty easy. So you can get it from, car exhaust. There are people who commit suicide by parking their car in the garage. And basically what happens is carbon monoxide disassociates oxygen from hemoglobin. Well, the affinity, which means the attraction of hemoglobin to carbon monoxide, is 212 times higher than its affinity for oxygen. So if you replace carbon monoxide with oxygen, eventually you get hypoxic and cyanotic and respiratory failure, and you die. Okay, so I got thinking, okay, so is there something replacing oxygen? So is it a replacement of oxygen? So you remember I told you about the non-structural proteins? Okay, so there's a study that came out, was published Thursday from China, that showed that the non-structural proteins of this virus, so you got structural proteins and viral replication, and once the cell lyses and you got all that material in there, the non-structural proteins appear to be binding to iron. And of course, iron is the cation, positive charged ion, that is binding to oxygen in a hemoglobin molecule. Okay, so if this protein is replacing iron, then you got a problem. And depending on how fast and furious that goes, then you are going to deplete your ability to transport oxygen to your tissue, and then you start seeing multiple organ failure, which is kind of what you're seeing. Morning, Christy. Okay. So basically, if it's displacing, then you got a bunch of iron running around, free iron ions running around in your bloodstream. Well, what does that do? Well, what that does is your body has to scarf them up, and it makes ferritin in order to bind with those iron ions so that they can be stored in the liver. So ferritin comes from the liver to scarf those up. And it is a marker that I've used for chronic inflammation for probably 6 years. If I do a ferritin level and it's elevated, I start looking at other inflammatory markers. Men tend to have a higher ferritin, and if their ferritin gets high enough, they can actually deposit iron inside their organs. So I tell most men, just get rid of blood about every 3 months. Just donate blood. It'll reduce your iron stores. Women, on the other hand, because they menstruate, tend to be a little bit iron deficient and anemic. So their hemoglobin levels can be a little bit lower. Men's are higher. And what they're seeing in these patients is they'll see, and like especially ones that die, and so on postmortem testing, they're seeing high ferritin levels, which indicates that the liver is responding to free iron in the bloodstream. Okay, so there's two forms of iron. You can eat them both, but iron 2+ is the cation that binds to oxygen. Iron 3+ does not. And if you start getting if you start getting increased free iron in your bloodstream, it starts doing this. So a lot of the chronic disease process that we deal with, and this is why I think that people that have predisposing conditions like hypertension and heart disease and chronic lung disease, COPD, and diabetes, they all have chronic inflammation. They have inflammatory markers. You can measure them. You can tell them how inflammatory they are. And there's a thing called reactive oxygen species. What most of you know that is free radicals. And free radicals are inflammatory. They're toxic. Not all of them, because you need some free radicals or reactive oxygen species from your immune system and your macrophages. That's how you fight infection off. But if you have chronic inflammatory radical formation, and it doesn't really have to be free radicals, it can be known as just radicals, but most people know it as free radicals. Well, guess what happens when free iron is running around? It converts hydrogen peroxide, which you make a little of, in your blood, and it will disassociate hydrogen peroxide into hydrogen ions and a hydroxyl ion. The hydroxyl ion, which is OH with a negative charge, so it's got a free electron to donate or give. So hydroxyl ion is the single most toxic radical that you can form. Okay, so when you get hydroxyl ion formation, little radicals, here's what it does. Wreaks havoc with your cell membrane. So it's got an electron. So I always tell people, if your free radicals are high, it would be like thinking about little oxygen-related molecules or species of oxygen with little charges running around through your body, electrocuting you from the inside. You just can't feel the shock. That's not quite accurate, but you get it. You kind of get what I'm talking about. So if you had little electrons running around electrocuting you all the time, probably not good for your body, right? Okay, so the hydroxyl group has that free electron, and it can donate it and react with phospholipid. Okay, so phospholipid is part of the cell membrane. So the cell membrane is made of a bilayer of phospholipids and cholesterol, etc., etc. But the phospholipids are what create the membrane structure. Morning, Linda. Okay, so if you have a hydroxyl group that will react with a phospholipid, it will put a free electron on a carbon-centered phospholipid in your cell membrane, which then makes it reactive to oxygen. And so you have oxygen dissolved in your plasma. So that oxygen will bind with the free electron on a phospholipid carbon atom. And that reaction creates peroxyl ion. And peroxyl ion is the second most toxic free radical that you can have. So you have this perfect destruction, creation of free iron converting hydrogen peroxide to hydroxyl ion, which then binds with a carbon on a phospholipid of your cell membrane, and then oxygen reacts and creates the second most toxic free radical that you can have in your body, and eventually you just continue to deteriorate with multiple organ failure. If your cell membranes don't stay together, then they get leaky, everything gets leaky, you get organ failure, everything stops working. Okay, so overall, I didn't figure all this out, but I have seen two studies that are basically talking about this virus displacing iron out of the heme of hemoglobin, or the globin, or the heme of hemoglobin, and displacing oxygen, which of course would make you hypoxic, low oxygen levels. You're not delivering oxygen to your tissues, which is required for metabolism and aerobic respiration. So if you have none of that going on, your entire system is just going to start shutting down. What they've seen, so the people that they're seeing that are at the highest risk for death are older people, we've heard that, but not always, because we've heard of younger people, and men. And what they're seeing is an elevated ALT level. So that's a liver function test or a liver enzyme that you see elevated in cirrhosis, hepatitis. It's ridiculously elevated. So cirrhosis, alcohol abuse, so ALT will go up, and that's what they're seeing on these patients that get really, really ill, is an elevation of their ferritin level and an elevation of their ALT level, which is different than just saying, well, your oxygenation is depleted because it's a respiratory problem. So there is more going on than just saying, oh, these people have ARDS. They might eventually get ARDS, but this doctor is saying, well, yeah, but we're treating it like it's ARDS, and it doesn't look like ARDS. And then ventilatory stuff, I haven't used a ventilator. I've been around them, but I haven't used or been involved with setting a ventilator since I was a resident, maybe even before that. And ventilatory support for patients has changed significantly since I was in med school and residency in the 80s and the early 90s. So things have changed a lot. But what seems to be the problem in this guy's mind, and several of his colleagues as well, is that we are using high pressure ventilatory oxygen, and we're probably actually destroying lung tissue when we probably need to change the pressure settings on a ventilator, watch the tidal volume so it's not blowing up the lungs. So like he said, think about a thick-walled balloon versus a thin-walled balloon. An ARDS patient has a thick-walled balloon lung, and a high-altitude sickness person has a thin-walled balloon lung. So if you put more pressure on it, it's gonna damage the balloon, right? I mean, you could damage the balloon either way, but so he didn't specifically say look at blood, but apparently other people are looking at blood. The question is, and like he said in his video follow-up, is this a respiratory disease with a blood component end game, or is it a blood disease with a respiratory component end game? So it's changing, and it's changed a lot in the last 8 or 9, well, I'm going to say 8 days. So that's what I got for you. Hopefully I explained that so that it makes a little bit more sense. I tried to downplay some of the jargon. But that's the basic physiology of lungs and hemoglobin and oxygen carrying capacity versus the pathophysiology of if you destroy your hemoglobin and iron starts pouring into your bloodstream, you start free radicalizing your blood, which is going to just destroy you. So chronic disease is really, most of the time, is inflammatory, and it involves oxidative stress, and that's what we're talking about is oxidative stress. So hit me later or send me a direct message, private message, whatever they call them these days. And if you want to interact, I'll set up a Zoom meeting maybe this evening, and then we can talk back and forth instead of you guys just being able to comment. So I did that in 40 minutes, so that's not too bad. At least you're not in my physiology class. I drone on for 2.5 hours. Okay, good to see you all. I'll talk to you later, and as I find more stuff, I'll do this again. Okay? See you later. Bye.